just getting it to stream on Zoom, and then it will get started. Okay. So good evening, everyone. Thank you all for joining us to stream on Zoom, and then it will get started. Sorry about that. So good evening, everyone. Thank you all for joining us today. My name is Cristina Rodriguez. I'm a case manager at the University of Miami, Nova Southeastern University. Good evening, everyone. Thank you all for joining us. Can you hear that? On Zoom, and then it will get started. Yeah, you can. Okay. So good evening, everyone. Thank you for joining. I'm gonna have to pause it on here. We'll just blast it later. So again, good evening, everyone. Thank you all for being here today. My name is Cristina Rodriguez. I am a case manager at the Center for Autism and Related Disabilities at Nova Southeastern University and the University of Miami. And so if you're not very familiar with CARD, our mission is to provide support and assistance with the goal of optimizing the potential of people with ASD and related disabilities. So one topic that often gets brought up is the topic of therapies, and how can you be sure that the therapies that your child is getting are appropriate for him or her, right? So in the spirit of that, today we're going to be showing you some of the resources that we have through CARD, as well as talking with some of our community providers and with Dr. Yaneris Leon, who's here with us today, and we're going to be giving you some of that information today. So I'm going to pass it over to Ivan, and then yeah, we'll go from there.
Good evening, everyone. So before we get started with our whole panel, I wanted to share a few of the resources that we have available to our families and to really anyone out there, even if they're not registered with us. We want to spread the word a little bit more about some of the things that we've been working on. And so we've created this Padlet that is, I think that everyone can see, yeah. So basically, we're putting together this Padlet, which will have a bunch of behavioral strategies for anyone to access. And as of right now, we have a little video that we created on reinforcement that's sort of funny, you know, it's just 1 minute content. And we've added some other articles and other resources that families can look through. The idea is that really going forward, we would like for families to know that we have this resource available. And so we're going to share this link with you at the end of this presentation. We'll send you an email with all that information. You're going to notice that in the bottom, we'll also have QR codes for 2 separate surveys that we're conducting right now. And we would love it if you take the time to complete those, as those will be very helpful into determining what kind of other services we can provide to you guys. In addition to that, I'm also going to include in the email a link to our YouTube page where we have a bunch of trainings that we've recorded in the past. And so for instance, we have a training series that's both in English and Spanish where it goes into ABA. And this is ideal for families who are just getting started into getting some ABA services for their children, or, you know, that they're any type of individual, whether it's an adult or a child. So if you can take the time to look through that, you know, that would be great. If you have any questions about it, then don't be afraid to reach out to us and let us know. Okay, thank you so much.
Hi, everyone. Thank you for joining us today. I'm just going to quickly introduce the purpose of our panel today. So like Christy mentioned in the beginning, you know, selecting the right kind of therapy and the right therapy model is a really important choice that many caregivers have to make. And sometimes identifying what is good and what is not good therapy can be a little bit of a challenge. So the purpose of this panel today really is just, you know, educational for caregivers and families who are either currently receiving ABA therapy or who are seeking ABA services, to have a good context or understanding of what good ABA practice looks like. So we have some great panelists here. They're going to introduce themselves shortly, that have slightly different approaches to treatment. So in addition to just getting a good kind of understanding of what is best practice. We also wanted to give families a little bit of an overview of different types of ABA service delivery models. So without further ado, I will get started with our first question. In general, the format is we have 4 general topic areas that we're going to cover related to general practice, assessment, parent involvement, and then treatment and supervision. So we're going to go through those 4 topics with each of the panelists, and then we will take questions from the audience at the end. So to start, I would like to give the panelists an opportunity just to talk about their general service delivery model and give us this here. And I'm sorry, I teach for a living, so I don't know how to do this. That doesn't look like I'm teaching a class. Like all of my PowerPoints always end up looking like this, but just to have a little bit of text on the slide. Some information about the place of service, for example, the client served. Oftentimes we get questions about like, which company should we go with if we want services in home or in school or in a clinic. So I'd like to give this opportunity to our panelists to give just a general overview about their service delivery model. So who, should I just unmute people, or does someone want to go first?
So really quickly, if anybody, any of the attendees have questions, on the bottom of your screen, you should see a button that says Q&A, and you can ask questions there, and then at the end, we'll bring it up.
I'll go. Because one thing I've learned about myself recently is I don't like awkward pauses. So I get drawn into things. Hi, everybody. My name is Dr. Barbara Davis, and I am with Little Leaves Behavioral Services. We provide center-based services to children in that early intervention age range, typically from the time of diagnosis, so about 18 months, until they're ready to go to kindergarten or some other preschool placement. So typically between 2 to 6. We utilize a comprehensive approach to therapy. So most of our kids are with us between 30 to 40 hours a week. And we offer all of our ABA services in a preschool-like environment. So one of the things that I think stands out is that we're able to provide all of the focus on all of the different skills levels that the kids need in a very focused approach to tailor to them individually. But then we're also providing those school readiness skills as well as those socialization skills, and really setting it up to look like a classroom so that when they transition, it's not something that's really surprising. We also offer community-based services in a limited capacity, mainly for our kids as they're transitioning out. We work with families during the transition process, whether it's to kindergarten or earlier if it's more appropriate. And we will help get them into the right placement, as well as if they need, we will provide school shadow services in a transition capacity to make sure that we're really setting them up for success. Did I answer all the questions? Did I hit them all?
Yeah, I'm gonna ask one more of you, because since you brought up the preschool, one of the common questions we get, particularly for early intervention, is should my kid go to preschool and have therapy after, or should I do full-time therapy? Could you speak to that a little bit?
Yeah. Absolutely. We get that question all the time. And obviously it's going to be an individual decision for what's best for the child. But one of the things that we talk to families about is that if you think about your child's day, and neurotypical children are learning through imitation, they're learning through play. And if you think about what that consists of, they're awake 12, 13 hours a day times 7 days a week or times 5 days a week for a school week. And they're learning every moment of that day. They're taking in information. And children with autism and other disabilities learn a little bit differently. And so what we say is that this is a crucial time. We really want to maximize all the different learning opportunities in a day. And to do that, really having them in a program where they're getting one-to-one support, and we're focusing on maximizing each and every learning opportunity so there's no downtime, is really what we talk to families about striving for. We've gotten families who have come to us from preschool and they say, my child the teacher says he's doing okay, he's doing fine. And we talk to them about how you're right, he probably is doing fine, but in that 30-minute circle time, is he learning every minute of that circle time? And if the answer is no, then that's when we say, okay, so then maybe another setting is going to be the best for now for you. And as quickly as we can, we'll happily walk you out the door and into another preschool or kindergarten program.
Great, thank you. I think that's really helpful for some of our families who are trying to make that decision.
Absolutely.
Hi, everyone. I guess I'll go next. My name is Kalel Alicea. I am the founder and president of Lotus Behavioral Interventions. I am a BCBA with over 20 years of experience working with children on the autism spectrum and families as well. It's a pleasure to be here with you all today. At Lotus Behavioral Interventions and I have prior experience before I founded my own company with a clinic-based model, but I'll definitely be focusing on today with home-based ABA therapy services. We also do a bit of community-based services as well, but mainly home. The clients that we serve are anywhere from early intervention to even some adults. We currently service a 36-year-old, for example. But we do have children that we service that are as young as 2 years old, newly diagnosed. In in-home services, we very frequently focus on early intervention skills for the little ones, but we also very quickly start with the social skills for children that are going to be school-aged with other same-aged peers. Once they transition into preteen years, we really focus a lot on self-help skills and independent living skills as well, even though you can always work on those for very young children. So for example, we can do a lot of potty training and, washing hands independently and things of that nature. So we always tailor all the treatment goals specifically to the child's individual skill level at the time. As far as our treatment, we do, because services are in home, they can be comprehensive for the very little children that we service in the home. Because, for example, let's say mom is a stay-at-home mom and the baby is home with them all day, then we can definitely provide a more intensive level of care. But a lot of our children do attend preschools or do attend regular public schools or private schools. And so a lot of children do get a more focused level of care. So for example, we'll see them in the afternoon hours after they get home from whatever school setting they may be in during the day. We do focus on all kinds of things, both across skill acquisition or teaching the child new skills and behavior reduction as well. And I think what's really important about our home-based ABA therapy model is that we have the opportunity to really focus on a lot of parent coaching, a lot of caregiver training, which is where some other clinic-based models may fall a little bit short. So if you have a child that you are having trouble engaging with at home, that you're having trouble managing their behavior problems at home, then you may definitely want to consider home-based ABA therapy services, because we will provide you, the therapy team in general will provide you with the tools that you need to succeed with your child at home. A lot of our families have multiple children in the home, so we also work very closely with siblings. It can be a younger sibling, you know, it can be like a 2-year-old that we're treating with autism, learning to accept a new baby in the home, or it can be a child with an older, an older sibling, you know, learning how to share and learning how to take turns playing and really improving that quality of play, so that it does become a learning experience for them. And we also focus often with grandparents, nannies, babysitters, the next door neighbor who sometimes pops in and provides intermittent reinforcement for a problem behavior that we want to nip in the bud. And so again, clinic-based services are excellent. ABA home-based services are excellent too. It's always just going to depend on what would be best tailored to your individual child and family.
Thank you, Kalel. That was great. I want to just kind of reiterate to the families out there, when you're receiving home-based care, the importance of that really kind of integrated approach with the family. In a couple slides, we're going to talk about, what therapy should look like, what family involvement should look like. And I think some of the best in-home ABA providers really take kind of a whole family approach in terms of parent coaching, like Eric said, sibling coaching, neighbor coaching, and really kind of getting everyone on the same page and, kind of circling back to what Barbara said, maximizing those learning opportunities. If everyone in the home is trained on how to best interact with your child, then all of those are potential learning opportunities. So the in-home ABA really can integrate the whole family.
Hi, everyone. My name is Ifat, and I am the owner of Everything Behavior. Thank you for inviting me to be here. It's really exciting. I'm a BCBA, and I've been in the field even before I've gotten my BCBA for a little over 20 years, actually, since I moved to the United States. So this is really my calling. It's not a job. So I actually do things a little different in the sense that mainly with regards to the population that I work with. So we provide ABA services at homes and also at schools. And I'll talk about that in a second, but we work with kids or individuals regardless of their diagnoses. So some of our clients have autism, some of our clients don't have any diagnoses at all. Some of them have ADD or ADHD. It really, for us, the diagnosis is important in the sense of it's informative, it's information. It tells us a lot about general characteristics and skills, deficits and strengths, etc. However, we treat behaviors. And so parents may call us for their children who are as young as sometimes 1.5 years old, and as old as 16, 17. And we really work on whether it's challenging behaviors where parents tell us we cannot control this child, we don't know what to do, they tantrum, everything is a battle, everything is a no, they don't sleep, they don't eat, all of those different challenges that parents go through, again, whether there is a diagnosis or no diagnosis. We do know that parenting does not come with a manual. So many parents that call us have read books, have attended workshops, and those are fantastic, and they should still keep on doing it. However, those workshops and books are not in the home. They don't account for the little intricacies, the dynamics between the families, and the interaction, and what buttons have been learned to be pushed for mom, and what buttons have been learned to push for dad and for the neighbor, and all of those things. So our treatment is really focused heavily on the parent training, on the caregiver training, if we're in the home. If we work with individuals at schools, if they have a hard time at school, then we would very much incorporate the teachers into those trainings. The entire process from the very beginning, from the assessments until the end, The caregivers or the adults are a huge part of it. I can come up with the best treatment in the world that's backed up with science, but if it doesn't mesh or it doesn't work for the family dynamic, that particular family dynamic specifically, it's not going to be effective. So, so for us, the biggest part is the entire family, parent treatment, parent coaching and training from the very beginning. And like I said, a wide variety of challenging behaviors and also skill acquisition, but a little different from what the early intervention model, more of the skill acquisition with regards to if a child has a hard time staying on task, sitting in circle time or staying on task at school or things like that, then we would help the child create a behavior plan, train the teachers, train the parents on what to do so that they can be better and we can shape up better and better focusing behavior.
Great, thank you, Rifat. So I do see some questions already coming in the Q&A. Keep them coming. I think we're going to go through the 4 target areas that we have, and then I'll read out the Q&A to the panelists. So the next topic we have is the assessment process. I want to give the panelists an opportunity to talk about what assessment looks like in their service delivery model. In general, all intervention should be preceded by an assessment that is going to functionally inform what that intervention should look like. But depending on the service location or the target behaviors or just the general context of treatment, that assessment might look a little bit different. So I'd like to give the panelists an opportunity to talk about in their practice what best practice looks like and what families can expect in terms of who should do the assessment, how long should it take, if there's any continued assessment during treatment, and any other notes about assessment. So if it's okay with you guys, we can just go through the same order to kind of keep the flow going. Okay.
Sure. So our assessment process is ongoing. But what I would say is, and what we talk to families about when they call us, is our startup assessment process is a series of 3 meetings. We have, in the beginning, we have an intake meeting is what we call it. And that's where we're getting a lot of the background information. We get a lot of reports and paperwork filled out, but it's always better to hear it from the families. What is going on? What are your concerns? And we ask questions. So it's very interactive, very much just an open dialogue. And that helps us inform the assessment tool that we're going to be using. The other thing that we do in that first meeting is we watch the caregiver or caregivers play with their child. So that tells me a lot. Because one of the things that we really like to do is start considering goals for parent training right up front, right from the beginning, and not just what I think the goals should be as the behavior analyst, but what the family values. What is going to make your life better? So we talk about that from the beginning. Then from there, we will do a few different assessment tools. Most commonly, we use something called the VB map. It's a long name, stands for, and I'm probably going to butcher this, the Verbal Behavior Milestone Assessment and Placement Program. Essentially what it is, it's not a standardized tool like some of the assessments that you would get at the neurologist's office or with a school psychologist. It is based in the principles of behavior analysis, but it's also developmentally normed, which I think is very important. So it is an interactive observation-based assessment. So families come to our center during, in the thick of COVID, we were going into homes, but mainly they come into the center and we essentially play with the kids. It should be fun. We want the kids to enjoy themselves. And we also want the parents to feel comfortable. And what we're doing is we're assessing different skills. So the VB map, we like to talk about it as being broken down across different, think about it like domains, all the different things that kids do, They communicate their wants and needs. They label their environments. They have conversations. They play. And it just keeps going and going. So we assess across all of those. And then we also assess up the developmental trajectory. So for example, benchmark a child by the age of 18 months. Benchmark a child by the time of 2.5, and so on and so forth until you're up to 4. And our goal with that is not to say your child is functioning at a 2-year, 3-month level, because kind of like what EFOT says, it's just a label, right? It's just information to have. We're more so looking at where are we starting so that 6 months from now, where will the child be relative to where they started? And we also use it as it's a really important tool to remember that a lot of kids have splinter skills. So, your child may have an excellent memory and be able to recite all 50 states or, anything like that, but they're not able to communicate their wants and needs when they get frustrated. And so we're looking at how we can fill in those gaps, basically. We also, depending on the referring concerns, we'll also do assessments of challenging behavior. We typically will do those right up front if we see if that's one of the parents' primary concerns, or if when we do the assessment, the VB map, the child really isn't available to us, right? They're not available to show us their skill set. We'll probably bring the family back in and do a functional analysis. And after that, we write up the report, we put together all the goals, and we have another meeting and we present it to the family before we ever submit it to insurance, because the family is the main stakeholder. We are a team, and the child and the family, whomever is in that family, is the most important part. So we go through everything, we explain everything, and we change things as needed. And then we submit it to insurance and begin services. I will say that we talk to families in that feedback meeting, we call it, about how this is a working document, right? It's a live document. I am meeting as a BCBA with your child 2 hours, 3 hours. I may not have seen the best. They may have fallen asleep right before they got there. They may, not shown any problem behavior, which often happens. So we are always doing assessment. We're always reevaluating the goals that we have, and we'll often work with families and say, a couple weeks into treatment or even months into treatment, you know what, we are going to reassess early, right? Because he's making so much progress, or we're seeing more problem behavior, which is okay. And we want to stop and do a functional analysis now. So that's typically what we do. I will say, to answer Yanni's question about who is involved, the BCBA who will be overseeing the case is always the one who leads it. And we typically have one of our, we call them specialists, but it's like a residency program that we have. And so we have one of those members of the team participate throughout as well, because they're actually the first therapist that the child's going to have is going to be that specialist. And so we want to start building that relationship early. I think that's it.
Yeah, thank you, Barbara. I think that's super helpful. The kind of big take home with respect to assessment in the context of early intervention that I think Barbara touched on a bunch, and I'm sure we'll hear from Carol next, is the feedback loop, the constant reassessment, and kind of looking at where are we going? Are we actually getting there? I think in terms of assessing your own providers and how this is working out, not having a provider that's so rigid, right? That would not reassess early if, gains are happening, or that is not afraid to take a pause because problem behavior is occurring, to shift treatment goals, to more closely map onto what the kid needs at the time. So a little bit of, like behavioral flexibility within the context of the assessment and treatment planning process. You're talking about stakeholders, which is the next thing. So you're getting ahead of us, but I appreciate you talking about that already. All right, so Kalel, next.
Yes, hi everyone. So again, I definitely think what Barbara touched upon mirrors a lot of the manner in which we practice the assessment process at Lotus Behavioral Interventions as well. I think it's really important to mention at this point that we do implement a 3-tiered service delivery model. So it's important if you're seeking ABA therapy services for your child that you're familiar with that model so that you understand who should and who shouldn't be conducting these different levels of services. So for assessments, as Barbara mentioned, typically a BCBA, a board certified behavior analyst, is the one who's going to be expected to definitely take the lead. A BCBA D doctoral level or a regular BCBA, which is a master's level practitioner, are both equally qualified to be the supervisor on a case. Now, the next certification level below that would be BCABA, which stands for Board Certified Assistant Behavior Analyst. And Board Certified Assistant Behavior Analysts are often also called upon to assist with the assessment process. Again, they should not be completely in charge of the assessment process because we are credentialed by the Behavior Analyst Certification Board, or the BACB, which dictates that BCABAs must practice only under the supervision of a BCBA. So yes, you may have a BCABA helping, for example, to conduct a FAST on the side, which is just like a behavioral interview with a parent regarding problem behavior and when they're most likely to occur. So for example, if a child is tantruming, does it usually happen when you take a favorite toy away? Or does it usually happen when you leave them alone and they, no one's paying any attention to them? And so we do that in order to discern the function of the behavior, which will then tell us how to treat it appropriately. So anyway, so a BCABA may at times be called upon to help with part of the assessment process, but it should definitely be a BCBA who's doing the majority of the legwork. We also at Lotus start with a really solid intake interview. We also have the parents fill out a lot of paperwork, which is sometimes difficult to get back because we know you guys are so busy with work and with your children. But it is a really pertinent portion of getting a correct assessment for your child going. So we'll ask for medical records. You're going to want those handy. We're going to need any developmental assessments that have been previously done by maybe like a licensed clinical psychologist or neurologist of any type. We're going to need speech therapy evaluations. We're going to need occupational therapy evaluations, physical therapy if your child had any of that for whatever reason. If they have any like fine motor impairments from very early on, for example. So you're going to definitely want to gather all that paperwork so that before the intake process, which is the very first meeting, we have time. The clinical team is already kind of put together and we have time to review it. I guess what differs for us, because we basically focus on home-based ABA therapy services, is that our intake interview usually takes place at your home. So we come to you, the BCBA would come to your home and sit with you for typically 2 hours. We really want to make sure we dive in and we get through all those little details. I want to know what your priorities are as a parent. What behaviors do you want to see increase for your child? What behaviors do you want to see decrease for your child? And just to talk about expectations, right? Like what's the assessment going to look like? What place in your home would be the most ideal for this assessment to take place? What I really love about being able to assess a child in the home is that we get a firsthand point of view on the child's natural environment, right? Whereas if you conduct an assessment in a clinic, you may not necessarily see a lot of those idiosyncrasies that, like, for example, we can get to observe the child with brother, with sister, with mom, with dad, with grandma. We can have a FAST or an FBA, a functional behavior assessment done that's particular to not only to that behavior, but also to the individual and the consequences that are coming into contact for that child's behavior. So it really allows us to get a really in-depth look at the behaviors that we're going to be helping to treat. So again, as far as who does the assessment, I think I was clear on that. How long it typically takes. This is another one that I think we sometimes, parents can be a little bit surprised. They're like, you still have to assess? Like, can't we just get started already? And unfortunately, oftentimes, it really just depends on the child's skill level, to be honest, right? Because if we have a very early learner, for example, if we have a 2-year-old who's newly diagnosed, who has very little vocal repertoire, they're barely speaking, they may have a little bit of echolalia, but have very few skills in general, like, are not really making eye contact, don't really know how to play appropriately with toys, engage in a lot of self-stimulatory behavior. The assessment for that child will probably be much, much shorter than, for example, if we're starting an assessment with a child who's, 7 years old, more high functioning, newly diagnosed, maybe because they always had very advanced language skills, always was mainstreamed in a regular classroom setting, and all of a sudden is just having some trouble with maybe like social interactions with other kids at school. And so that child is clearly going to have way more skills, and we're going to have to dig deeper and deeper and deeper so that they get credit on all the skills that they're able to do, the skills that are currently in their repertoire. So, I mean, you're basically looking at, as set forth by the Behavior Analyst Certification Board, an assessment can take anywhere very commonly from 6 hours to 20 hours, and it kind of just depends. So please be patient with our practitioners. Just know that we're doing the best we can to get started on the right foot. And then, yes, we also use assessment tools to guide our practice that are pretty standardized for our field. The VB map, as Barbara mentioned, is definitely one of them. Another one that we very commonly use is the ABLES, which is the assessment of basic language and learning skills. And then the AFLS, which is the assessment of functional living skills. And so between those three, we sometimes pull from others, but those are definitely three that you'll see, I think, as pretty much standardized assessment tools in the field of ABA that help us to help educate us in formulating our treatment plans. And yes, there's always continued assessment, as we'll talk about a little bit later. We're constantly, and when I say we, I mean the BCBAs, we're constantly supervising the work of the therapists, whether they be ABA therapists, or RBTs or BCABAs, whoever it is that's delivering the actual service one-on-one with your child on a day-to-day basis. The BCBA who's assigned to the case should definitely be supervising and reassessing on a very continuous basis moving forward. So that's definitely something you want to look for as far as best practices in the home.
Thank you, Carlex. That was great.
Yeah.
Okay, so I'm going to echo some of the things that have been said and then add some other things. So in terms of who should do the assessment, absolutely a BCBA should always do the assessment, or a BCABA. But the BCBA is the person that supervises, that leads it. Those are the credentials, and literally, or BCBAD, those are the credentials that you're looking for. Anybody who does not have those credentials should not be conducting the assessment. Of course, if the BCBA is leading it and there's other people who participate, sometimes there is a BCBA that's leading it and an RBT is helping they're both in the same place at once, that could also be okay. But the BCBA is the one who's mainly doing it. For us, because our model is a little bit different, because we don't just work with kids on the autism spectrum or related disabilities, because we work with kids who are typically developing, then our assessment process is a little different. It's a little shorter because we don't do the assessments with the child specifically, the learning needs assessment. We don't do the VB-MAP or the ABLES. We actually go straight into observations. Because we're in the home, we go straight into observations, looking at the interaction between the parents, between the siblings. I would come to the house at 6:30 in the morning whenever kids wake up for school to observe that. Oftentimes those are really challenging moments. Or after school to observe homework, to observe bedtime, to observe meals. And for us, it really depends on how much information we get from those observations. When we're in a home, I kind of joke around with the parents that for a short period of time, we become part of their family. So we're very informal because what we want to do is to decrease the chances that because there is a stranger in the house, all of a sudden, the parent will tell me, I don't know who this kid is, but he's not mine. So because the child will change their behaviors, sometimes the parents will change their behaviors for better, for worse, just in reacting to somebody else's presence. So we become we're very informal. We just so that it's, they feel comfortable, it's their own territory. So we see pretty quickly all of everybody's beautiful colors, the good, the bad, the less, so this we can do anywhere between, I would say 3 observations and 6 observations. Every observation can be anywhere between an hour and 2 hours. Again, we try to pinpoint it on challenging times. So we will never come just when the child is watching TV, unless transitioning off the TV is a problem. So we'll come a little bit beforehand. Of course, our intake meeting, which I should have started with that, but our intake meeting, which takes place first, very similarly to what was described before, about 2 hours, very lengthy with regards to, I want to know everything. I want to know their challenges. I want to know what they've tried before, what succeeded, what failed. A lot of the parents that come to us have tried many things before and have experienced failure or disappointment or frustration because it feels like it's not working. And so I want to know all of that. I also, part of what I want to know is, of course, their priority, and also some information, because parent training for us is so critical. We also want to know during the intake information about the parents themselves. What kind of a parent in their ideal world would they want to be? And then what does it look like now? Why do they think that they're not able to be their best version of themselves? Because we will incorporate that information in the parent training. Just like we would use reinforcement with the kids, we would oftentimes use reinforcement with the parents to motivate them. It's a really big change. Behavior analysis, it's very simple, but it's not easy because of all that history of doing things in a certain way. And so what we're asking of parents is literally changing everything. Sometimes what we recommend may not come naturally, or may be completely the opposite of how they grew up. So this is a big shift for everybody. And even though, of course, the parents love their kids and there's nothing they will not do for the kids, it's still a big change. And so from the beginning, from the intake meeting through the observations, through the feedback meeting, which we'll talk about, I believe, in a minute, Yanni? Okay. For us, they are a huge focus. So in terms of how long does it typically take, I would say depending on the scheduling, it's really mainly logistics and how quickly we're able to get to see the interactions, the behaviors, the dynamics, etc., so that we can be informed enough to create a really good and individualized and function-based behavior plan. It can be anywhere between, I would say, maybe 4 and 6 weeks, something along those lines.
Thank you, Ifat. That was great. So just some take-home points related to assessment for the families that are viewing. The main things that you want to be looking for really is, number one, was an assessment completed, right? So someone should not be coming into your home or doing a treatment without having completed an assessment. You wouldn't take your kid to a pediatrician and accept antibiotics without having done some kind of test to show that, they need that. So the really the bedrock of your treatment comes from the assessment. So that really should be the first kind of point. The second is that it really should be done by a BCBA, led by a BCBA, a credentialed person. And the third is that it needs to involve observation of the kid, either doing the thing that they shouldn't be doing or not doing the thing that you want them to be doing, right? So Barbara and Carolex talked from the skill building perspective, early intervention. Those typically involve a little bit more of a standardized assessment. These are really meant just to provide the clinician an opportunity to see if the child is going to emit the behavior under kind of the best circumstances. And then if they don't, that leads to the plan about what skills you can build. When you're working with problem behavior, it's a little bit different because like Ifat said, you want to watch them in the most challenging situation. So if bedtime is challenging, the BCBA should come to observe them during that time. It doesn't help you for the BCBA to come and observe them at 2 p.m. in the middle of the day when they're happy because they just got home and they're having a snack, right? If the goal or the presenting problem is a problem that happens at a specific time, then you should reasonably expect that the assessment happens during that time. So, an assessment is done, it's done by a BCBA, and it involves observation of the kid in the relevant context. Those are, I think, the 3 main things that you want to be looking out for. So that takes us to our next point, which is treatment planning, which the panelists have already started to touch on this a little bit as we talked about the assessment process. So we can just touch on these a little bit now. In general, treatment planning should always involve the family. Again, I'll leave it up to the panelists to talk about how they incorporate the family perspective from treatment planning as it relates to the general goals. But you're the recipient of services. And if it is not important to you, then it really probably shouldn't be part of the plan. So I will hand it off to Barbara to talk about how they incorporate family input.
Yeah, so this is a great point because I really think to what we've all alluded to, the families are the most important part. And so we are getting family input every step of the way. From that intake meeting where we're talking about what your values are and what your goals are and what areas it would be really helpful for you to see improvement and how it would improve your family. That leads us into what we do is we have both caregiver goals as well as child-focused goals. So you're going to see both from the moment we put together that initial treatment plan. And what you'll see is that the child-focused goals are going to be surrounding all of those deficits that we may have seen, or some of the extra stuff that we don't want to see. And you may then say to us, I didn't see toilet training on there, or feeding. We forgot to mention in the intake meeting, feeding, such an issue. And so that's why it's that working living document. We then also, based off of some of the stuff that you describe as your goals, as your values, as well as that initial observation that we did of just play, we develop some initial caregiver goals. For the most part, we focus on them being sustainable and obtainable. I'd say obtainable and sustainable, because we all have busy lives, and I can't ask you to go back to school again. So we're focusing on participation, right? Getting into a good groove and participating. We really ask that our families participate at least once a month in a caregiver training session with the BCBA. That is our minimum. We will provide it as much as necessary. We'll provide it weekly, and in whatever setting is necessary. And we, move into some of the more specifics. One of the things that we like to do, and we talk to families about, and we can do this because we have a comprehensive model and the kids are with us for a good part of the day, is we say, don't ask us to, unless you want it, but we don't recommend that you ask us to just to teach you to do what we do, right? There's no need for you to sit down with your child at 5 o'clock in the afternoon when you both have gotten home and do more table work or, workbooks or anything like that. What I want to do is help you have a better family dynamic. So how to play with your child, how to get the child to ask for the things that they want at home when we know that they're doing it at the center. How to, toilet training is a big one, we generalize, doctor's appointments, all of those things are what we're really listening for in that initial part. Yanni, let me ask you a question. Do you want us to focus more so on what the families can expect in terms of their training, or best practice in terms of what types of goals and things like that are included? I can't remember what the fourth one is.
Yeah. No. So the next one is implementation and supervision. So really here, just, parent involvement. I was going to ask you if you could speak a little bit, and I'm going to ask everyone to speak a little bit also about not just in selecting goals, but perhaps in selecting procedures, not that the parents know the vast array of procedures available, but it's a little bit at that informed consent piece for parents to understand, operationally, procedurally, what are these sessions going to look like? What can I expect the interaction between the therapist and my kid? I think sometimes we hear from families that they're a little bit surprised about certain procedures being used. From our perspective, when we teach our students, we always ask them to, for example, get explicit informed consent if you're going to be using extinction. Don't just assume that the parents understand what that is. So if you can talk a little bit about how you involve the families and just informed consent about procedures, and if they have any input on the procedures, not just the goals.
Absolutely. So the answer is yes, without a doubt. We start that process in the intake meeting, and some of that comes into, like Yvette mentioned, what's worked, what hasn't worked. And sometimes families will say, the most common one I've gotten lately, in addition to what do you do if my child's crying, I don't want to just, walk him through it. I don't want to, hand over hand guide him in that moment. And that's where we hear you and we say, all right, cool. There are many different ways to do this. So it's really about what's going to work for you and what you're going to be willing to do. So we do that. And then on the back end, when we talk about the treatment and we talk about the goals, that's a first part of that meeting. And then we spend a large part of the meeting about talking about what can you expect? What's this going to look like? When we talk about our training process, that's a big thing that we talk about. How, can the families meet the therapist beforehand? Can they, get information about the therapist? as well as what the day is going to look like. And how we respond. The biggest one is how we respond to challenging behavior, of course. But then also, we've worked with some families who have asked more recently about, well, how do you respond when they're engaging in some self-stimulatory behavior? And we talk to families from the beginning about, what is it that they're looking for? If they describe a self-stimulatory behavior as concerning, why is that? And we very much work with the family on exactly what procedures they're going to be willing to do, want to do, and how we go about that process and how we go about doing it. Like I said, I think the biggest thing that you can take home is that there's not just one way to change or teach behavior. There are many, many ways. There's kind of goes along with like the customer service model of the customer's always right. Behavior analysis, we talk about the child, the student is always right. And it's our job to figure out if something's not working, to work with the child and work with the family to figure out what else is going to work. Did that answer that?
Yeah, that was lovely. Thank you.
Mm-hmm.
I see now that we're already getting short on time, and this happens to me every time because I just like to chat and ask so many questions. So I'll quickly hand it over to Kalel Alicea, and I would just ask that, if whatever you were planning to say has already been said, you can just pass or just add relevant info.
Sure thing. I know time is of the essence. So regarding best practices, I guess what I'd like for the parents in the audience to understand is we basically just completed a really nice assessment with your child. And our job now is to help you understand the results of the assessment, to help you get a better understanding of where your child is along a variety of different developmental domains, so that together the clinical team and the family unit can come to devise the best treatment plan for your child and family. Very often that's going to, because our services again are home-based, we're going to have goals not only for your child, but for each and every one of that child's primary caregivers as well. So because we focus on home-based interventions, don't think we're just going to come into your home and, lock ourselves up in your child's bedroom and then, say, see you later when we're done. That's not what we're there for, right? We're not babysitters. We are ABA therapists. And this is, everything we do is very professional and it involves the entire family. And so when we come into your home, we talk about the treatment planning process, know that you're going to be a very active part of it, especially if you're getting in-home therapy services, because we're going to see you every day. So every single day you have the opportunity to say, hey, my goodness, this new problem behavior just popped up. And, we'll be like, awesome, thank you for telling us. We're definitely going to keep an eye on it. We're going to take, start collecting baseline data, see where we're at. And just know that we're going to want to observe it, right? We're going to want to observe that being done. So again, you're treatment planning, but you're constantly assessing and reassessing. And that's a really, really nice piece that you get with home-based ABA therapy services. Let's see, family input and involvement. Again, every single day, we're going to see you guys in the home. So every single day provides that opportunity for you. And absolutely, it's really important that you not only understand what all the different protocols there are in ABA therapy in order to improve behavior over time. And it's important that clinicians and the family unit really discuss to know like what it is you would be comfortable doing. Like maybe extinction wouldn't be right for your family because, you can't tolerate high-pitched screaming for more than like 5 seconds at a time. And so it's always really important for you to communicate that to your clinical team as far as treatment planning goes, so that you can modify your treatment plan as needed.
Okay, so I'll try to go as quick as I can. So a few things. Again, because our model is a little bit differently and we are not working just one-on-one with a child. So from the beginning, the parents are the most important part and they are involved from the very, very beginning. So depending if we're doing an intensive, like intervention, or if we're doing something more specific like toilet training or just sleep training or whatever it is, that will determine the length of our interventions. And the parents are needed throughout the entire time. So again, our whole model is we are working with the entire family the entire time. So one of the things that, again, that I've been hearing and I've heard in the past is that behavior analyst and ABA is all about robots and creating robots. And this could not be more of the opposite, especially, I mean, we're hearing the panelists here, this is all about flexibility. Like Barbara said, there's more than one way to do things. I can't tell you how many times I've worked with families that co-sleep. They believe in co-sleeping, they love it. Whether or not I think it's a good or bad thing is irrelevant. If for them is not a problem, and if this situation does not interfere with the child's functioning at home, at school, etc., if it's not hindering anything, it's not a problem. So so flexibility is definitely something that you should be expecting to find in a good clinician or a good organization. And then, like I said, you are part of the process. You are a huge part of the process. What you think, what you feel, what you want has a very big effect on what we will do. You basically can tell us what you want, and based on our information from the assessment, we can guide you in the right direction.
Thank you, Ifat. Again, so just to kind of wrap that one up, I think the main points that we want to drive home here are informed consent here should be very explicit. You should most certainly have involvement in selecting the goals and kind of understanding why the goals are being suggested in the first place, how that is going to look in terms of the child's development, and also procedures, right? So I think all three panelists said this, there's more than one way to do, to get to any goal. To kind of bring it back to the analogy of just going to the pediatrician's office, which I think everyone here has probably done. You might have a situation where your son or daughter has an infection and they might say, okay, we can prescribe you oral antibiotics. It's going to take 4 days of oral antibiotics until the fever breaks, but it's well tolerated, it's okay. Or we can give him a shot. It's going to hurt. They're going to cry. Their arm is going to hurt for 2 days, but it'll get rid of the fever today. Right. So there's a cost and benefit really to any time you have to make a decision about what treatment to approach. And the same thing is going to happen with your ABA therapy. You might have a problem and they might present you a solution and tell you, we're going to take a slow and steady approach. You can expect for this problem to resolve in a month. Or with this other approach, we might be able to get it under control in a weekend. It might be more intensive. It might have some other side effects. So there are multiple ways to get about obtaining the goals that you've selected. And you as the family should be informed about what those goals are and the processes and procedures. And that should be all part of the informed consent process.
Yanni, I wanted to add one more thing. So
yeah,
sorry.
Go ahead. Mm-hmm.
So we've talked about, we all agreed in terms of the parents' input, but one of the things that I sometimes get, and I think it's inevitable, we're all humans, we want to have a certain problem resolved, but we almost want it to be resolved without making too many changes. So it's our job as BCBAs to be as creative and flexible, that to stay within the principles of behavior analysis that are backed up with so much evidence. But the one thing that I always tell parents, that one of the things they should expect is something's going to have to change. So change will need to be made, because, if you do the same thing that you've always done, you're going to get the same results. So that's one of the things that, again, we can kind of like maybe soften the blow. I don't even know if that's really a sentence, but we can make things softer. We can try to make things work better for the parents, for you, for the parents, but they have to know things will have to change. To see the change and to see the results and to see improvements, that will require some work.
Yes, thank you. Yeah, I think I was erring a little bit on the other side of parent involvement, perhaps just because of some feedback we've gotten, but absolutely the parents are involved in the treatment planning process that is driven by the clinician. Okay, last one. And I think we probably covered some of this. I think the main thing here I want to touch on is the supervision. So I think Barbara and Kalel talked about this a little bit in terms of the model, where you've got a BCBA that's kind of running the show and developing the treatment. And those models, typically you've got an RBT that's going to be delivering service. Ifa, I'd love to give you some time here because I know that you have a direct service delivery model as a BCBA. So we can save a little bit of time for that. But when we have this BCBA RBT model, I'd like families to get a sense of what the supervision should look like, and kind of how do you know that your case is being well supervised, and that your clinicians that are working with your child are well credentialed. So go ahead, Barbara. Yeah, we'll start.
Before I talk about supervision, real quick, I want to take a little bit of a different approach with because we've already talked about the qualifications of the RBT and things like that. With therapy implementation, in terms of the dosage of treatment that's recommended, because this is a common question we get, in that the hours in ABA is a dosage of treatment, just as saying when you go to the doctor, you need to take 100 milligrams of this drug twice a day for 10 days. That is the best practice. That is what the science says is going to be most effective. And so your BCBA should be making that recommendation to you. One of the things that I see is that recommendations are unfortunately often made in terms of what insurance providers are going to be most likely to approve. And I think the biggest thing here is, what is your child capable, or what is necessary for the child? It's also really good to include information about, all right, well, how much are they available, right? Clinically, they're going to be, they would most benefit from this many hours a week. And in reality, they're only going to be available because of other services this hours a week. But should anything change, this would still be beneficial. So I think that's just something important to point out. And then best practices in supervision. So who does the supervision? I think everybody will agree the BCBA, you gotta have the BCBA. This involves live, in-person, face-to-face, sometimes telehealth because of COVID, supervision, watching session, watching the different RBTs and watching more than one of the RBTs, watching everybody across the caseload. And depending on the type of tiered model that you have, you may have that BCABA, or you may have that specialist, and they can provide additional eyes. How frequently? As much as needed, I would say, with the caveat of, our certification board gives a minimum. And at a minimum, we are saying 1 to 2 hours for every 10 hours of therapy. And this can include direct supervision. So I think that's important to note. This can include direct supervision, which is face-to-face and watching the child or trying new things out with the child. But it can also be and should also be the behind the scenes work, the looking at the data, talking to the team members, training the team members, writing the new programs. All of those things count as supervision. So really your BCBA should be in contact at least weekly in some capacity, whether it is in person or they're talking behind the scenes and looking at the data at least weekly, I would say. And then since I like to talk, I'm going to let everybody else add stuff.
Thank you. That was great. Carol-Lex, go ahead.
Okay, hi. Yeah, so as far as best practices go, with regard to the delivery of therapy, just know that it's going to vary broadly depending on your child's specific needs. So just to give an example, we have very high functioning children on the spectrum who only are seen once a week for 2 hours a session. And we also have very low functioning children on the spectrum who do not do well in a school setting, are homeschooled, and may get 30 hours a week of in-home ABA therapy. And so just know that the frequency and the intensity of delivery for ABA therapy can vary very broadly. As far as the supervisions go, again, I'll mention that at Lotus, we do implement a 3-tier service delivery model, which includes the BCBA at the top, the BCABA in the middle, and then the RBT. So 100% of our clinical staff is recognized by the Behavior Analyst Certification Board. So what you typically see is either an RBT or a BCABA in your home, usually every day, say Monday through Friday. And then what you'll have is the BCBA come in person once a week, typically, because the majority of our children are seen daily, Monday through Friday, at home, typically after school, kind of depending on their schedule. We do have children that we see at school as well for behavior problems and behavior management, and to train the teachers and whatnot. But we're basically in the home Monday through Friday. So you'll see the BCBA, for example, typically on Thursdays and Fridays. I like to schedule my supervisions toward the end of the week when the children, had a long productive week of a lot of learning, and then I want to review their progress toward the end of the week. So usually Thursdays or Fridays, you'll see our BCBA coming into your home, observing the RBT or the BCABA, doing the one-on-one clinical work with the child, or doing the parent training with the sibling or the caregiver training, rather, with a sibling, or however that service delivery looks like. The BCBA is going to observe. The BCBA is going to review the data. So as far as service delivery, you want to make sure, so we are a very evidence-based practice, right? Our science is very objective and observable and measurable. And what you should see during your daily home sessions is an RBT or a BCABA who's collecting data on your child, on everything your child is doing. How many times did the child scream that day? How many toileting accidents did they have? How many times were they taken? What is the percentage of accuracy for requesting preferred items? There were 10 opportunities and they only succeeded in 3. That's 30%. That should all be in paper, in writing, or in a tablet if the company uses a fancy software for data collection. But there's definitely data being collected every single day by either the RBT and the BCABA. And then when the BCBA or the supervisor comes in at the end of the week, then they're going to be reviewing the data that was collected during that whole entire week. And you're going to see them observing the therapy being ran, giving the RBT or the BCABA constructive criticism on maybe what to try instead if something isn't working very well, giving them feedback on what they're doing really well on. And then the BCBA should definitely take some time before they leave your home to have a discussion with you as to what the progress looked like for that week. If any new concerns came up, that should be the time when you're definitely discussing it, again, in person. And then supervision notes should definitely come after that as well. That should be shared with you. So our BCBA will document the notes for that session. Any improvements, any regressions, any concerns that you voiced should all be documented. We have our parents sign off on them as well, just to have very clear documentation that everyone is still on the same page, that we're still on board moving forward. And I think that's it. Let's see, who does the supervision, how frequently? I guess I would say we definitely like to stick to, I think we over supervise, if anything. So we tend to do, like, for example, if I have a baby who gets seen 3 hours a day, Monday through Friday, then I like to schedule a 3-hour supervision once a week. If, I like for my BCBA to be there the entire length of the session, I like for us to be able, I don't like missing anything, because if you miss something 1 week, a lot can happen. Then by the next time you get there, 2 weeks have gone by. And, you may have missed an opportunity to really rectify or troubleshoot any problems in advance. And so we like to definitely stick to the 10% rule, and it works pretty well. I think that's it for the supervision and the therapy.
Thanks, Kirsten. I'm gonna kind of wrap up your two, because before we get to Ifat, because Ifat's model is a little different. So just some take-home points for the parents about supervision. I think the main things you want to be looking for, that both Barbara and Kalel touched on, is the RBTs should be collecting data, right? So that is part of best practice there. The BCBA should be reviewing those data, and you should have some information about what the data look like. The BCBA should be observing the RBT, working with your child, and also meeting with the RBT outside of the actual session time to do things like data review, program updates, right? So program review, data review, those things should not be happening in session with your child, right? If the BCBA is there with your child, that is a time to observe how the RBT is working with them and give them feedback on kind of in vivo practices. And we call them office meetings. Those office meeting type things should happen in an office, not in the middle of a session when the kid is there watching you. So those are some things to look out for. The BCBA certainly should be in your home or at school or in the clinic very frequently, minimum 10% doing those observations and reviewing those data. Now, Ifat's model, she does direct work as a BCBA, which families I think oftentimes don't even know that that's an option, right? So sometimes we get calls from families that have more challenging needs. It's not a straightforward skill building type of early intervention model. Not that early intervention is easy, it's certainly not, but some of these cases, maybe an RBT is not the best person to deliver direct therapy. The 3-tiered model works very nicely for some types of interventions, but RBTs are the entry points of the field. So if you are a family that has a child with more significant needs, that needs a more focused kind of intervention, one of the things that I want families out there to know is there are other options. There is an option to pursue direct therapy work by BCBA. So now I hope I didn't put that too much on a pedestal, Ifat, but go ahead.
No, it's good. So yeah, I love working with the families. I enjoy being a BCBA, but I love the work. I love the direct contact with the families. I love to see the beginning and then see the end. And because our model is a little bit more, it also has like an intensive, meaning short-term intensive. So if we have some of those challenging situations, our treatment phase, not the assessment, but the treatment phase may look like me moving into your house for about 3 weeks or so. Not really, depends if you have also sleeping issues, and then I might stay there at night. But so I definitely love to work with the families, and for the most part, that's what's happening. I'll do the assessment and I'll also do the treatments. We do at Everything Behavior, we do have, it's a very, very small organization, but we have a couple of RBTs that sometimes either help me. So in certain situations for the first few days, we need a couple of people in the house. Sometimes it's one of us implements the plan with the child, and then the other one explains to the parents what's going on, brings them on board, etc., and supports the parents. Sometimes, depending on the situation, I'll start implementing it, and then they'll continue. So it really, again, it just depends on the case, the severity, the skill set, etc. Whenever an RBT is involved in the treatment, even though I am not physically there, I am spiritually there. Not really, but I am there. So I'm in touch with the RBT on a daily basis. I'm in touch with the family on a daily basis. I will stop by periodically. It could be multiple times a week, just to see how everything is going. And so again, a little bit different model of supervision from the previous panelists, but we work very, very close together. It's, you know, like Kalel said, it might be probably over supervision, but it's really because it's the direct contact is so important.
Thank you. Thank you all so much. So that is kind of our preset things we were going to talk about. I know we're I'm not sure how long people can stick around, but I'm going to go ahead and look at some of the Q&A questions, and I'm going to go a little bit out of order. So there's a few questions about, so from Sarah and from Bernadette and from Cindy. They're different questions, but some are related in terms of if my child is receiving other services, what can ABA provide that, for example, they might not get at speech or at OT, and can ABA only be used for skill acquisition types of things? So I think we've touched on that a little bit, but I would like to give the panelists an opportunity to speak to kind of what and how ABA fits in a model where the child is perhaps getting some other kinds of services, and working on idiosyncratic type behaviors. So if you can just speak to that a little bit, and we don't have to go through everyone, but if maybe one or two of you want to touch on that.
I can speak on that a little bit. I mean, I can definitely attest to the fact that a lot of parents that come to us have already been through other types of therapies with very little success. It's typically the case, right? So I'll get like a newly diagnosed 2 or 3 year old who maybe just, you know, always presented with a developmental delay, maybe started out with the early steps model of service delivery, which basically surrounding a little bit of speech and OT, maybe rendered in the home, or maybe they got private paid speech or occupational therapy. And they very often tell me that there was very little progress, even though they attended for a year or 2 years. You know, often, unfortunately, those therapies are very short in duration. They're typically 30 minutes long. And we know our kids, you know, that they're definitely going to need more than 30 minutes worth of one-on-one time with any practitioner, because I feel like sometimes in 30 minutes, you're just getting started and then your session's gonna be over. And so ABA therapy is much more frequent and much more intensive than any of those other therapies. I could definitely say, our sessions can be our minimum session time at Lotus is 2 hours, just because that's what gives us enough time to get everything done. Especially considering the fact that we're traveling to you. And so we want it to be worth everyone's time, right? So it can start at 2 hours, but it can be 3 hours, 4 hours, 5, 6 hours a day. And we are side by side with your child because of such a lengthy amount of time, through so many different activities for each session. And it can involve, feeding, which oftentimes is a skill that's worked on by speech therapists. We're going to work on a lot of language and communication skills, which again is going to supplement any speech therapies as well. We can work on, fine motor skills, and, tying shoes, brushing teeth and getting dressed, which are more like occupational therapy goals, but we work on them in a behavioral modality, which helps to really improve outcomes. It helps for the child to be able to learn these skills in a much more efficient and time efficient manner. And again, it helps everyone in the home kind of be on the same page. So again, speech and OT typically happen in a clinical setting. You drop them off, you're not even allowed in the room, you have no idea what's going on. ABA therapy doesn't necessarily have to be like that, especially if it's in the home. We're there not only to help your child learn all of these skills that are sometimes kind of redundant in these other therapies, but we're also there to help you coach them so that once we step out of the home and you're with them the rest of the day, you can also know how to help your child with these skills as well.
Just to add,
Go ahead, Barbara.
just to add to that real quick, I think one of, Carol's talked about the intensity, and oftentimes that's seen in terms of the hours, but oftentimes it's also seen, and we like to talk to it in terms of the repetition. One of the hallmarks of behavior analysis and why it works is because we're constantly practicing. We're taking a skill and we're breaking it down into tiny, tiny steps, and we're practicing, and then we're scaffolding it up. And so that's a strategy that we use, so that even though we may be trying to teach the same thing as speech and OT, we're doing it in a little bit of a different way. I will also add, and then Ifat, jump in, we like to work with the other providers. We are experts in behavior, which in essence is everything. Everything you do is some type of behavior. But I will tell you, I am not an expert in production of speech and how the mouth moves and how a child swallows and how the fingers work together. And so that's where we really like to collaborate with those other providers to get their expertise and our expertise and put it together with the family's expertise of the child and really get the best outcomes.
And then magic.
Magic. And I absolutely, Barbara, that's exactly what I wanted to say. And one of the things that I wanted to add is a lot of my families have other service providers, and actually part of my assessment before I conclude and I write down the report and the programs and all of that, I actually speak with all of those, of course, with consent from the families. And so I am all for collaborations. We each have our own specialty. One of the things that I've been able to kind of like help parents with choosing the right OT or the right speech therapy therapist is really also in regards to the goals. You as the parents are supposed to know the goals, to understand the goals, no matter who the provider is. If it's a language that you don't understand, or if it's something that doesn't make sense to you, or if it's a goal that you have no idea how to measure, he knows it, he doesn't know it, or etc., that's an issue, and that's something that you should absolutely talk to your other service providers. But collaboration is super, super critical, and if we all work together to support each other, there is magic.
Thank you. Yeah, and I mean, so we're a panelist of all BCBAs here. So we all very strongly believe in the power of applied behavior analysis. It can be absolutely transformative in the child's life, in the family's life. With respect to the types of behaviors that can be assessed and improved, I think the sky's the limit. So there's questions here about bullying, perseveration. I mean, those are all skills and goals that would be relevant in an ABA practice. Coming maybe back a little bit to assessment and reassessment and being a part of your child's therapy team. One of the things that really you should be looking for in a good service provider is that they are addressing the particular needs of your family and are not just filling the time with non-functional skills. So if you might have early goals for language, and then you might have a child that is 10, 11, 12 and has not developed language, that might be a time to focus on some other functional skills and not just labeling, right? So there are points in the progression of treatment that I think the whole family always needs to reassess together with the treatment team. What is the most functional for my child right now? What is the most functional for my family right now? And what is going to give my child the best opportunity to live a happy and independent life? We are running out of time, but I did want to touch base on one particular question from Cindy. So Cindy says, I've read some concerns in the community regarding ABA, reports of traumatizing experience as a result of it. What can you tell a parent of a newly diagnosed child to ease concerns about those accounts? And Cindy, to be honest, this is one of the reasons that we put this panel together. Like I said, we all here have seen the transformative power of good applied behavior analysis. I think in any kind of new profession like behavior analysis is, and really any helping profession, there's good players and there's bad players. And we want to empower families to identify what good ABA would look like. And, as a parent, so now I'm going to kind of take off my BCBA hat and put on my parent hat. I worry about the kinds of decisions that I make for my own kids. Sometimes they understand what we're doing. Sometimes they have the opportunity to assent. Sometimes they don't. I have that responsibility as a parent to put them in the best position, to seek medical care when they need it, to push them in a way that I think is going to promote growth, but maybe is uncomfortable for them at the moment. So I think, as a parent, we always struggle to, really understand if we're making the right decisions for our kids. In terms of, ABA and being traumatizing and kind of being in that environment, I think anytime you put your kid in a position where you're going to push them, there may be some uncomfortable moments and times, and that should be expected, I think, in any situation, in sports and school. If my kids woke up tomorrow and said they wanted ice cream for breakfast, I would likely say no, and that would result in some crying. So, those are just natural things that I think are a function of childhood, and a function of, learning to live in society. Now, having said that, there certainly are situations where, ABA providers might not be providing best practice, and you should not have any hesitation to pull your child from a situation that you think is dangerous or is, the program is not providing the appropriate level of expertise and supervision that you and your family deserve. So I think the short answer to that is that, good ABA can absolutely transform a child and a family's life. We are here at CARD. We are hoping to be part of the process of educating you as a family to how to identify good ABA, and help steer away from perhaps some bad players in the community. So if anyone has anything to add to that, I would love to hear that, but I think that will be probably the last topic.
Yeah, I have one thing to add, because this has definitely been something that we've seen and parents coming to us, and it's kind of twofold. The first being, nobody should ever discount another person's experience. right? I haven't walked a mile in your shoes. And what we're seeing at this point in time in our field, like Yanni said, we're a young field, is that we're seeing for the first time adults with autism who are able to communicate their experiences. And there's two sides to that. Unfortunately, these adults with autism experienced probably what everybody on this panel wouldn't necessarily call applied behavior analysis as it is run now, as it is today, as we've learned and it evolved as a field. And so a lot of, some of those techniques we don't implement. And we get consent and we do all of those things. The other piece that I always like to talk to families about is even though, yes, we don't do that anymore, that should never be the only response. And I really have pushed my staff to start to conceptualize and think about, okay, why are we doing this, right? What is it solving? What is our goal? And the real quick, just the stereotypy topic, I think is, it's really in line. I talk to families about how we cannot, at this point in time, if I'm working with a child who's non-vocal, I can't ask them why he's flapping his hands. I can't ask him why he covers his ears in loud places. But what I am certainly not going to do is, as long as it is not hurting him, as long as it's not hurting other people, and as long as it's not interfering with learning, I'm not going to stop it without some insight and being able to provide the child with another response, another behavior that is just as soothing for them, right? Maybe not as acceptable as we want it to be socially, but it's working for the child. And so that's a lot of the kind of care and thought processing that we go through now that I think is important. So I'll let somebody else talk.
Yeah, I'd love to add something. I would say to parents who are maybe feeling a little bit hesitant, maybe they watched something on YouTube that made them a little uncomfortable or saw some Facebook comments by like a high functioning adult. I mean, I would say honestly that whenever I've come across them as well, and they're always super shocking to me. I've been in this field, again, over 20 years, and all I've seen is how much our clients really, really love us. They're always so excited to see us. They're so excited to play. I think professional ABA practitioners really focus on positive reinforcement and really forging a really nice relationship, just like an amicable relationship with their clients. I mean, our children are always asking like, oh, is Josh coming over today? Or is Annie coming over today? And they get excited to see us. They want to show us their new toys. And so again, a lot of ABA therapy is structured in a way that it's fun, that it's play-based. Especially if it happens in the natural environment like the home, you have a little bit more flexibility. Yes, it's structured because kids really do thrive off structure, but it's fun. It's fun and they really do love us. And so I would say don't feel any sort of a reservation. That's never been something that I've encountered in the 20 years I've been in the field. Again, I think so long as you're sure that your clinicians are recognized by the BACB, you go to the website, all you have to do is type in bacb.com and you look up your practitioner, you should definitely be in good hands.
Thanks, Carolix. And actually, Ivan messaged me mid talk. We showed the Padlet at the beginning. So one of the things we're going to do is add some resources about the BACB registry so that families can have a little bit of background information about how to check if your provider is certified, how to check if your everyone that's coming into your home is credentialed. So we'll add that, and then Ivan will send that information out to everyone. So I just want to thank the panelists for spending the night with us today. And thanks to all of the participants who came for your questions and for participating. Of course, if you are a card constituent or a card client, feel free to reach out again to your case manager if you have any other additional questions. We're happy to answer. I'm supposed to go through some other slides, right, to show that, Christy?
Yeah.
Is that what this
I'm
is?
going to add, can I just add something really quick?
Yeah, go ahead.
Super quick. So as far as schools, Adele, I'm seeing that you're putting that regarding schools. So each school district sort of manages things differently. For example, in Miami-Dade County Public Schools, the related services are limited to physical therapy, occupational therapy, and speech and language therapy. And I believe that works the same way for Broward. So you would have to see within your school district what types of related services they provide. So for example, like I said, in Miami-Dade County, you wouldn't be given ABA therapy. Now, if you are in Miami-Dade County or if you are in Broward and you need some recommendations for that, just reach out to your card case manager. And if you don't know who that is, you can just, email the main line with the question or email the main email, or you can just call us and we're happy to direct you. And if you're not registered with card, we're happy to help you with that as well. We have a page for that too. And then what Dr. Leon has up now is our training evaluation survey link. So if you all attendees, if you can scan that or use the link to be able to just evaluate, how you liked today's survey, that would be really helpful for us as well. Bernadette, if you want to find, so if Lynette Estrada unfortunately no longer is with us, so you can call right here. We should have there. So you can call that main line, or you can, that's probably going to be the best way to go. I'm going to, let me see. I'm going to send you a direct message with my email. If you can't get in contact with anybody, or if you want to email me directly, I'm happy to connect you with our admin team.
Alrighty, so I guess we are done for the night. The other thing I did want to mention, if you have other topics that we did not cover today that you would be interested in, we're going to put together a few other panels over the summer. So again, feel free to give that feedback to your case managers, and we will hopefully be putting together a little bit more content to help everyone navigate their treatment decisions. But thank you so much for joining us, and I hope you have a good night.